Hello, good morning. My name is Peter Bull. I'm a consultant radiologist with a cardiothoracic interest based in the Royal Victoria and Belfast City Hospitals in Northern Ireland. I would like to thank the organising committee of the SCCT and BSCI for giving me this opportunity to speak on our experiences with the spectral cardiac CT imaging on the Philips Icon system over the past 4 years. We are a bit spoiled in Belfast, having currently 3 spectral CTs in Belfast, with 2 more potentially coming online in the next year, COVID dependent. We probably have more spectral CT scanners per head of population than anywhere else in the world at present. And every year we like to celebrate this fact by lighting up our City Hall with spectral colours, which luckily coincides with the annual Pride celebrations. The concept of spectral imaging is nothing new. Sir Godfrey Hounsfield recognised the potential for multi-energy imaging from the outset. In his acceptance speech for the Nobel Prize in Physics, Sir Godfrey stated, "Two pictures are taken of the same slice, one at 100 kV and the other at 140 kV, so that the areas of high atomic number can be enhanced. Iodine can readily be differentiated from calcium." From AJR to ClinRad and JCCT to EJR, there's been a huge amount of data published on dual and spectral imaging CT over the years. This has mostly been focused on non-gating images due to limitations in acquisition. However, in our experience, spectral CT is starting to encroach into the once sole territory of the cardiac MR, with the increasing possibilities of robust perfusion at lower radiation doses. I always think of this quote from Einstein as very relevant when speaking about spectral CT. If you do what you always did, you always get what you always got. And this is relevant because Einstein was awarded the first of his Nobel Prizes in 1905 for his work on the photoelectric effect. So in honor of Einstein, unfortunately a little bit of physics. And when it comes to physics, I always find that less is better. Spectral CT is based on the 2 components of the photon interaction, the photoelectric effect and the Compton effect. So as a quick refresher, put very simply, the photoelectric effect is the incident photon which hits the atom. An electron from the K shell, which is the inner shell, is ejected. And this vacant space is filled by a neighbouring electron which drops down, releasing a photoelectron. Each atom has a unique K shell binding energy. And I must say the only one I can ever remember is iodine, which is 33 keV. There's then a significant spike in attenuation if the incident photon has an energy just beyond this of the K shell for the atom. And so the probability of this happening is when the energy of the incident photon is just above the binding energy of its shell. The photoelectric effect is therefore increased by the atomic density of the material, such as high in iodine, and reduced by the energy of the incident photon. And this sort of explains why, when you've got a lower tube voltage, when it's been selected on a conventional image, the iodine can look very bright. The photon effect is named after Professor Compton, a US physicist, who was awarded the Nobel Prize in 1927 for his effect, the Compton effect. I always think of this as a bit like a pool ball hitting another. The speed or energy of the pool ball is reduced once it hits another ball. The Compton effect is due to the interaction of the photon, which in imaging is either an X-ray or gamma, with free electrons, which are either unattached to the atom or loosely valent in the outer shells. The resultant incident photon is scattered, i.e. changes direction, and imparts energy into the recoil electron. The atomic number henceforth does not have an effect on the Compton effect. So why are these 2 effects important in medical imaging? The x-axis on this slide shows the energy the photon has, and at lower energies the photoelectric absorption effect predominates, whereas as the energy of the photon increases, the Compton effect becomes more important. And this sort of again makes sense because at higher energy settings on the tube, everything tends to look flat at 140 kV. So this is important in spectral imaging. The difference between the photoelectric effect and the Compton effect can be analyzed and used to differentiate between atoms or structures of different density. This can be used to separate or remove certain materials such as iodine, bone, or uric acid, to give a few examples, as Sir Godfrey mentioned on the previous slide. There are a few different methods of acquiring dual or spectral imaging. In dual source, there are two tubes and two detectors. One can be set at a lower kV, the second to a higher kV. Alternatively, the tube current can be very rapidly changed between 80 and 120 or 140 kV, the so-called kV switch. The most basic method is scanning the patient twice at different tube potentials and fusing the images. And the fourth solution does not involve varying the tube output, but is detector-based. Before this, I just want to make a slight clarification on the nomenclature. The difference between KEV and KV. The KEV is the maximal voltage in the X-ray tube. The KEV is the kinetic energy the electrons gain as they travel through the voltage. E is very small, usually meaning that these are more or less the same. And so in conventional CT, there is a spectrum of photons with different energies that are emitted from the X-ray tube. The continuous curve is due to the bremsstrahlung, whereas the spikes are dependent on the metal target. And in CT, this is tungsten. So, for example, in the graph on the left at 120 kV, or the graph on the right, 100 kV, the majority of the photons emitted have the energy between about 60 to 80 kiloelectron volts. The dual detector layer, or dual layer detector, is a sandwich of detectors comprising of yttrium, which absorbs the lower range of X-ray photon energies, whereas the gadolinium oxalate layer absorbs the higher energy of photons. And this produces the spectral data, or the SPI files, as it's known as, which means we can reconstruct numerous image types. We've got the monoenergetic images, which is attenuation of single energy rather than a normal spectrum obtained. Material decomposition images, which is mapping or removing substances of known attenuation characteristics such as iodine and calcium. We also have virtual non-contrast, iodine concentration, calcium suppression, effective atomic number, and so on. And what this does is, as it says here, gives us a workstation full of images. The spectral images can be loaded onto a dedicated workstation, or the reconstructions can be performed at source in the CT and sent to the PACS system. We have different reconstructions for cardiac, dedicated urogram, liver, and CTPA reconstructions. And this is basically dealer's choice of how you want to set it up. The icon's not just a dedicated cardiac CT scanner. We get a lot of different sequences, and it's a bit like MRI, that we're able to get different images for the same lesion, allowing for improved interpretation. And this is just a quick example of tumor thrombus in the portal vein, which shows enhancement in iodine uptake, and is tumor thrombus rather than normal thrombus, which obviously impacts on the way the patient is managed. So just before I go head first into cardiac, I have a rule of threes for spectral imaging. Things that should be there that aren't, things that should be there that aren't, and things that you wish you hadn't seen. So things that are there that shouldn't be. Firstly, this is an example of just hemorrhage and retained products in a patient. And you can see the iodine boost in the bottom left-hand corner shows us the iodine, and the virtual non-contrast removes it. We can also use this to our benefit in reducing the dose to the patient with a single acquisition CT urogram with the use of virtual non-contrast conventional and low monergetic images. And we find that this reduces our dose by about 30 to 60%. Where this really comes into use as well is things that are there that shouldn't, that are things that should be there that aren't. The CTPA is now, we have this set up that the reconstructions are sent, and we have an iodine no water and Z effective, which allows the assessment of iodine perfusion. And this is especially useful when there's queries of whether there's a filling defect in the peripheral arteries and whether these are real or not. And lastly, the things you wish you hadn't seen. And this is useful for nodules in the adrenal, for example, where the virtual non-contrast can be used to look at the attenuation value before contrast was given. So back on track, spectral imaging and cardiovascular imaging. An acquisition on the icon is basically the same as every other scanner. Cardiac imaging can be performed either as prospective or retrospective scanning. The rotation time and hence the temporal resolution is quick at 0.27, which is really very important for cardiac CT imaging. And most of the time, let's face it, the cardiac list, it's what I like to call either the Tesco's or Target or Walmart scan. The patient gets on, the patient gets off, the report gets done, and everybody is happy. Low dose, low stress, limited higher cerebral function, nothing fancy. Usually in the NHS patients, the images, the arteries are non-occlusive. In the private sector, it's often sort of highly motivated, and the chest pain usually comes on after 20 miles of marathon. Again, probably non-occlusive disease and probably hiatus hernia. The most important people are, however, the techs, and nothing beats a great tech. In our institution, they bespoke the patient for the clinical question using all the information and not just the patient's size. They take into account the patient's age, clinical history, calcium score when judging whether this is going to be the lowest dose of scan possible or the most clinically relevant scan. And the advantage of having the dual layer solution is that the spectral data is always available. We have it at the high temporal resolution and also a wide field of view. We don't need to pre-plan this, and there's no real compromise. The spectral imaging gets useful when the cases get interesting. There's a lot going on with the more complicated CTs, and any additional information that we can squeeze out of the data set is only going to improve the sensitivity, quality, and specificity of our reports. And hopefully this gives us an even more holistic approach to our reports. To put very simply, this can aid diagnosis. The iodine boost potentially allows the salvage of studies with limited contrast or a washed out contrast appearance in larger patients. However, conversely, no matter how much it is boosted, if there's no contrast present, this confirms our suspicion that there is an occlusion. In this example, we can see in-stent restenosis. So now a quick amuse-bouche of when spectral imaging is really useful in cardiac images. These are a few cases from the collection that we have been building up, which are added to almost weekly. This case shows a 44-year-old male who presented with ventricular tachycardia. Echocardiography showed RV wall thickening. He had a pacemaker inserted and he was referred for cardiac CT, query occlusive coronary artery disease. A retrospective cardiac CT was performed. Firstly, the coronary arteries appear normal. The CTCA also confirmed the wall thickening that was seen on the echo. However, the spectral images show the low attenuation in the RV free wall, which represents infiltration. This is really brought out on the low mono E images, which draw the eye towards the difference in the attenuation between the normal RV and the abnormal RV. And also because it was performed on a retrospective scan, we were able to do cine imaging, which again shows the lack of motion within the RV free wall. So this was a case diagnosed as sarcoid, but how were we so sure that it was sarcoid? Well, in the wide field of view, we've also got that available. They showed calcified lymph nodes and parenchymal changes, which would be consistent with sarcoid. Just to confirm it, the PET was performed, which also showed uptake within the RV free wall and within the nodes. And this is not an uncommon finding that the patients present with AV block, ventricular tachycardia, and ventricular fibrillation. And diagnosis can be difficult on an ECG and echo findings. This is another example of cardiac mass. An unfortunate 19-year-old presented with shortness of breath and cardiac sounding chest pain. On his chest x-ray at parenchymal changes, his white cell count and CRP were normal. Cardiology was contacted and an echo was performed in the emergency department. This showed severe right ventricular dilatation and impairment. The patient was referred for cardiac CT and was performed on the spectral scanner. And as you can see, the virtual non-contrast study confirms the presence of calcium within this lesion. But there is more. Reviewing the spectral data shows a significant perfusion defect within the lung parenchyma. The right PA does not show any occlusion, as you can see. However, there is significant compromise of perfusion, and what was noted is a problem with the right upper pulmonary vein. The lesion also looks at as well away from the mitral annulus, and CT imaging didn't show any prolapse or obvious compromise of the mitral valve, and the LV appears to fill normally. And these are just some further iodine perfusion images. The differential diagnosis can be above. Thrombus was felt to be unlikely as there was no enhancement of the soft tissue on the iodine no water images, and calcification is an unusual appearance. A myxoma is also possible, however, the position and appearance were also felt slightly unusual. And the differential diagnosis includes sarcoma, and these are very rare tumors which usually involve the right atrium. The patient was taken to theatre. The pathology showed an intimal sarcoma with osteosarcomatous differentiation. Unfortunately, the patient reappeared last week, and recurrence was confirmed on a further spectral CT image. This is an example of one of our first scans that we performed on the ICON scanner. This is a 53-year-old who was presented with increasing chest pain, predominantly atypical, but increasing on exertion and no other risk factors. We were still sort of finding our feet somewhat. However, the spectral data really helped to convince the clinician that the patient should be sent to the cath lab. The patient was cathed the following day, the LAD was stented, and everybody was happy, especially us. And all this for a relatively low DLP of 211, and this was retrospectively acquired. The monoenergetic images do help in pseudo perfusion defects, and often we will just check the mono-E images before we call this. Chronic thromboembolic pulmonary hypertension can be a diagnostic dilemma requiring multiple imaging modalities such as HRCT, CTPA, echo, and VQ scanning, and sometimes even cardiac MR and right heart cath. This is a male patient who presented with increasing shortness of breath and possible CTEPH. The conventional mono-E images show the typical signs of pulmonary hypertension: a prominent main pulmonary artery, banana sign, and a bikini bottom sign. Instead of the usual triad investigation, we are currently reviewing the possibility of a single acquisition gated study. The gated CT has the advantage of looking at the lung parenchyma for either chronic lung disease or lung parenchymal changes associated with pulmonary hypertension. The Z effective shows nicely the patchy perfusion defects with color imaging. And again, this was confirmed by the appearance of the VQ scan. And as these scans are performed retrospectively, fixed slice reconstructions can be performed throughout the cardiac cycle. This gives us functional-like assessment of the RV, such as TAPSE, RV ejection fraction, as well as PA size. And when combined, the information provided improves the diagnostic accuracy, and hopefully the patient can then start therapy sooner. And finally, a 54-year-old presented to the peripheral hospital with increasing shortness of breath. He was concerned that he had got cancer, he had weight loss and slightly atypical symptoms. The CT was originally performed and suggested the patient might have sarcoid. However, echo showed mild aortic stenosis. PET was indeterminate and EBUS was non-diagnostic. The images were reviewed at the regional meeting and something didn't really quite add up. So why does he have nodes? Well, on close inspection, there appears to be a problem with the pulmonary venous drainage. This appears long-standing as there's calcification present. A spectral gated study was arranged to combine the combine assessment of the cardiac vessels. The patient had previous stenting, and the cardiac CT showed no in-stent restenosis. But once scanned on the spectral scanner, you can see quite nicely the difference in perfusion in the left lung to the right upper lobe, and this was confirming the suspicions of a problem with the pulmonary venous drainage. The PA fills normally, as you can see. When we dug into this, we found out that the patient actually had a history of previous ablation. Thankfully, this is a rare complication which happens now in only about 0.3 to 3.4% of cases. The patient was referred for consideration of revascularization of the pulmonary vein due to its progressive symptoms. However, unfortunately, this was unsuccessful. And there is so much more that we're getting from spectral cardiac CT imaging. And just to reinforce the point, reviewing the vessels in different energies can improve the degree of certainty of severity of disease. A low KEV gives us iodine boost, whereas a high KEV gives us a reduction in the calcium blooming. This can also be very useful in stent imaging. The lower and higher mono E images can help to assess the presence or otherwise of in-stent restenosis. And this is a nice example of in-stent restenosis on a low mono E image in the bottom right image. Another nice case of an AV fistula where spectral helped to make a decision of whether the patient was actually going to go for intervention or not. The iodine no water image showed a reduction in the perfusion in the territory supplied by the LAD, and so the patient went for coiling. Left atrial appendage thrombus or pseudothrombus is always a diagnostic dilemma in patients with atrial fibrillation. The case on the left does not show any difference in attenuation or iodine concentration within the left atrial appendage, indicating that this is thrombus, whereas the case on the right shows that there is increased iodine uptake and that this is a pseudothrombus. And what we have found that an iodine concentration over about 1.2 milligrams per mil has a high accuracy for identifying pseudothrombus. We also use this for the follow-up of left atrial appendage occluders, and this example shows nicely the thrombus within the occlusion device, but also the iodine surrounding it and also getting into the left atrial appendage, which is consistent with device failure. And as I've alluded to before, because we're doing retrospective scans, we can also get quite a lot of functional assessment. And even I've encouraged our trainees or fellows to look at the spectral images and look at the spectral images of the heart when they're doing their routine scans. When I started radiology, basically the heart was a big muscle in the middle of the chest that we ignored. But we can get so much more information. And in this scan, we can actually see on the iodine no water the area of ventricular or myocardial scarring. So what does the future hold in spectral imaging? Well, first of all, material decomposition and identification of vulnerable plaque. At present, the spatial resolution is still a limiting factor, and we sometimes struggle to reproduce this, especially in smaller lesions. However, there have been multiple solutions, and these will soon become commercially available. CT perfusion is still fraught, and there is problems with beam hardening. However, the mono E images, as I showed in the previous imaging, can be reduced by using a higher mono energy, and this produces more robust and reproducible dynamic imaging. The dose of cardiac CT is getting lower and lower. The days of getting the above appearance are thankfully becoming a thing of the past. Bespoking the patient imaging and taking into account the other risk factors, such as age, calcium burden, and device implantation, should all be considered. And finally, I would just like to thank the team of radiographers in Belfast who have to put up with my endless tinkering. Thanks to all the UK and Ireland application specialists who, as a result, have to undo all my tinkering. And finally, just thanks to my mentor who inspired me in CT and sadly passed away this year, Dr. Paul Hanley. And finally, thank you. If there are any further queries or interests, I'd be delighted to hear from any of you at the above email address. Thank you.